Hello, and thank you for joining us for another episode of Hope for Healthcare with Dr. Katie Cole. Dr. Katie Cole is a holistic physician, organizational well-being consultant, and change agent, working with industry leaders and proven strategies to heal our national healthcare system and our culture of medicine. Stay tuned to hear today's speaker.
Well, welcome everyone to Hope for Healthcare. This is a podcast in which we interview expert leaders around the country on best practices for healing our national healthcare system and our culture of medicine. I want to extend a very warm welcome to my friend and colleague, Dr. Michael Privitera. And many of you who are followers know that I interviewed him, I think, over a year and a half ago. So a lot has happened since then, and I'm excited to introduce him today. Dr. Privitera is Professor Emeritus of Psychiatry at the University of Rochester Medical Center. For the past 14 years, he has developed and applied human factor ergonomics science from human-machine application to human system organizational ergonomics application. This approach promotes integration of patient safety, clinician well-being efforts, understanding greatest influences on both safety and well-being are systemic factor effects on humans doing the work. He is one of the 5 founding members of an international collaborative for human factors, cognitive load, and well-being in healthcare, now with a membership of 74 professionals. He was faculty of Institute for Healthcare Improvement in Boston for Workplace Change Collaborative, HRSA grant as an organizational coach for 4 institutions out of the 44 participating. WCC was a product of the Lorna Breen Bipartisan Act of Congress. He is now a member of the NIOSH, which is the National Institute for Occupational Safety and Health, Office for Total Worker Health, and NIOSH Healthy Work Design and Wellbeing Program, Healthy Work Design Council. Well, welcome, Mike. It's wonderful to have you back on the podcast.
It's good to be here, Katie, and thanks for having me. It's good to see you again.
Yeah, it's great to see you too. And I'm excited to hear all the updates that are happening on your front with human factor ergonomics. And would you mind just telling our audience a little bit about your own journey with healthcare burnout and how this has impacted your career in terms of adapting HFE as a way to not only define burnout, but also to measure and create solutions at a system level?
Absolutely. As you go back a little bit, is some of it became more clear early in the career. I was previously in the field of workplace violence and understood and got mentored by a colleague from Australia named Vaughn Bowie. And Vaughn had his expertise in organizational contributions to workplace violence. And so I had the real pleasure and honor to work with him on a few projects. And he taught me so much about what the organization tends to do and what the system does, which came in extremely usefully in the changes that came with healthcare reform. It was around that same time, 2008, 2011, in that range, when so many new things were happening. And I was looking to my right and my left, colleagues, and seeing them kind of like so worn out, and yet kind of asked to give more. And, your availability to the patient, which is the whole reason why people are there doing what they do, the calling of medicine, but yet couldn't achieve what was needed. So the idea of something's in the way, I sort of felt it, and then trying to put terms to everything. What seemed to be really a strong force was the Institute of Medicine's To Err is Human, and the idea that the patient safety movement came from that. And there was a big emphasis on what you can do to prevent error. But the trouble with that, certainly an important thing for us to do, but they're added to what we already do. I call it kind of orthogonal to our usual flow of what we do clinically, instead of trying to weave it in. Extra things, extra trainings, and then the idea of, you need to be educated more. So changes in our national boards, in terms of the frequency, expiring credentials became another issue, not only with our boards, but mandatory educations. It's good for a year, you got to do it again next year, that kind of thinking. And then everything changed between electronic medical record that was not so easy to use, as many of us know,
Yeah.
And it isn't a matter of just of getting used to it. It's the structure of how everything is designed. But how to get past the kind of thinking that was going on, particularly in leadership? How do you make a case where this is not good? Humans cannot do it. Where's the science to help us? Because certainly you can't get emotional about it. People don't want to hear emotions. Yes, you're struggling. But the idea is the more you have data and science behind you, then maybe there's a chance by that you can kind of cut through some of these barriers for appealing to leaders who can then hopefully go to more national groups after they see the problems. But it was the idea of kind of a halo bias that occurred. And I think that's a big thing because we call it quality, therefore it must be good, therefore we don't challenge it, therefore we don't try to go against it. Of course, we want safety. But the idea is adding one times something isn't the same as 1,000 times that as being safety promoting. So I went in the literature and found eventually a science that, it's used in pilots and it's used in astronauts, it's used in our industry of transportation, human factors and ergonomics. So that led me to some science to help with the case that we can't do this, we're human.
Absolutely.
And we're not whining. There's science behind it.
Well, absolutely. And I'm grateful that you stumbled upon this, Mike, because this has been actually a great area of discovery for the healthcare well-being community and the movement. And I know that you have done a lot on your part you created the Human Factor Ergonomics Collaborative that meets monthly, and you've been publishing quite a bit lately. So I know one of the most recent areas of work you've been collaborating with is the NIOSH. Can you talk to us a little bit about that and their interest in healthcare well-being? Because I didn't even know about this, so I'm really excited to learn about it today.
Yeah, NIOSH has been interested in total worker health for some years, and I got involved because our hospital system was a affiliated member, so I got to meet some of the leadership back then. And after I clinically retired, which was June of 2022, I continued to be in contact with their leadership. So about different things and kind of awareness of things of connecting the dots that seemed to make more sense about the science of human factors and maybe how that can help us from the occupational point of view of being a clinician. And they had a group certainly that was trying to understand healthcare workers in particular. So I finally got invited to some of their groups. So I'm kind of a guest to NIOSH. I don't necessarily work for them, but I review some of their training modules. And we recently wrote an article as a guest author with the leadership of NIOSH's Total Worker Health Program that had to do with, if you want to help the well-being of healthcare workers, you must be working on changing the system that's creating the damage, the harm.
Well, yeah, absolutely. And so, one of the things that you talk about in your article that you wrote is that, in terms of a healthy work design, there are a lot of issues with the environment that are contributing to extraneous cognitive load. Can you talk about some of those from a healthcare perspective for physicians and even nurses and what we're dealing with on that front?
Yeah, yeah, thanks for the opportunity. It's in healthcare, in terms of regulations, they may come from various sources. If you're an airline pilot, they have to funnel through the FAA. So one regulator. In healthcare, there's many that influence the finances, a sense of what quality is, what accreditation is, and then the issues of how the hospital gets paid, how the clinicians get paid. All those things have influences, become bosses actually to not only the hospital, but the clinicians doing the work. So there's many authorities in healthcare. And so when you you look at many attempts that are somewhat siloed. Sometimes the authorities, well, many times, most of the time, they do not communicate with each other, and they have the authority to impose what they think is best, and well-meaning. Sometimes in the payment scheme, it's not so well-meaning. Let me put it that way. It's about cost control, and it's about wearing people down so they don't pursue things, which isn't so well-meaning. But in the patient safety land, it is tending to be well-meaning. But because there's so many sources, they're not harmonized. They don't try to fit into the workflow. The issue many times is mandate without resource. So a new educational law says, well, you got to do this training, and by the way, we're not giving you resource for it. So the hospital may not necessarily understand the life of what's going on at the interface with the patient. Some of that being the disconnect between the leadership suite, the C-suite, and clinicians doing the work. And to some degree, our framework, which has been somewhat triple aim based, which is about costs and quality and patient experience, doesn't necessarily have to include any input at all from the clinicians doing the work. So all these regulators can go through the C-suite, but since there's no feedback system from those doing the work, it just keeps adding up. So there's multiple ways of doing the same thing that creates extraneous cognitive load by the fact you're building in a lot of unnecessary components to achieve what the primary purpose, which is the intrinsic cognitive load. And what comes from that is worry about legal risk, worry about, did I say it once or twice? They may say it 2 or 3 times, which is repetition that may not be necessary. The fact that different software might be involved, that slows the person down and may take 2 or 3 times as long to complete like a training just because the software was not helpful and too complicated. So all that is extraneous to what the mission is, extraneous to the achieving whatever it is the resource or the regulation is about. And because there's so many authorities, it's only at the level of the hospital itself where you can do something about it, because they're above and beyond where the hospital leadership is. So the work that I've been trying to do is, what can leaders do to help organize some of this massive input that's needed for payment and everything else, but do it in a way that achieves what's needed, but not the extras.
Well, and you were able to do some of that work when you were a professor at University of Rochester.
Yes, yeah, in our wellness strategic planning work group. I was there for about 7 years doing that. It's mostly trying to get the understanding of what the human factor engineers concepts are, but our leaders are not engineers, and physicians or nurses aren't engineers. So how do you make it understandable to a so-called layperson, a non-engineer? And that's what I've been working on for 14 years.
Yeah, well, thank you. I'm grateful for the work that you are doing. And can you talk a little bit about the concept? We talked about extraneous cognitive load, and one of those being work outside of work as well. I think that's an important concept to review because that doesn't get enough attention as far as I'm concerned. So can you explain about the shadow work and what that means?
Yeah, sure. With technology being involved, some of the changes that have occurred is the adaptation to technology is so rapid, but us as humans are not able to keep up with those changes. Our own adaptation is slower. So we have to be really intent upon how we can bridge that gap and realize there is a gap to begin with. So some of the ways that gets missed in technology is once it's been put into a system and you're the end user, shadow work is the work in the shadows that doesn't get up to leadership or other people that can end the stress, basically. And so it's in the shadows, meaning it comes up like Okay, your startup of your computer takes several minutes. Okay, now there's a new version of it. You weren't so up to date on that. That takes longer. That's shadow work. Or breaks down. You have to get on the phone with information technology. That's shadow work. Or now, because the things that are in the background, like for an administrator who may not have communicated to you that there'll be different nurses that work in a different area that are now working with you, the schema of their screen, the way it was designed for them, may not be the same one they're used to in the clinic. They have to adapt to that. That's shadow work. And basically what it means is it's work that is not seen. It's in the shadows, but it consumes your day. It could be as little as the light bulbs are not working and you're seeing your patient and you're somewhat in the dark, or there's a lawn mowing going on outside that you weren't aware that in a really intense moment, you need to be able to hear your patient and they're right outside your window. All those things add up. And the point being, it's in the shadows. And so how do we get feedback systems and understanding these play a real role on your performance and how you're doing and taking care of the patient? So they're kind of sneaky. They're affecting the safety of the patient. And the point of human factors is to kind of help leaders to understand how they do. So therefore they can be minimized by people that would make decisions, the decision makers, basically. It's helping decision makers to understand the impact of their decisions. The Institute of Medicine, 1999, to Err is Human, told us that the greatest source numerically of medical errors are due to systems, but yet what we keep working on is individual solutions, and very little is worked on the system. Human factors in the macro ergonomics is what is the greater system look of ergonomics, is also called organizational ergonomics, is an attempt to get at the system. What can you do to improve your system to make it smoother? You're not wearing out the clinicians. You're not asking their brain to be working on so many other things, the extraneous cognitive load, that they're highly trained and you're wasting their brain resource on things that either other people can do or should be improved so they're not wearing it down. Because actually that brain power needs to be recharged. It's a limited source, and that is something Human Factors helps teach. It has to be restored, and that's why the importance of work outside of work comes in. Because sometimes many people are salaried and it doesn't affect the bottom line of the hospital to see, people are finishing their work off hours. And it doesn't influence, except for the fact, the indirects, like, well, then people get tired and they don't want to work there anymore. They move. So there's the attrition there. It's how it affects safety. You wouldn't want to be seeing a surgeon that's working so late on their notes the night before when they should be sleeping for your surgery so that they're well rested.
Absolutely.
All those indirects are not, as Human Factors helps make that all relevant.
Well, it's definitely a different way of looking at system level stressors that are affecting burnout. And I think it's important for healthcare leaders to understand these concepts as well. They have a lot of science behind them, and they've been used for, how long has human factor ergonomics even been around, Mike? I'm just curious.
Well, it started off certainly in the physical land. Trying to remember if it was in the early 1900s or so. It came from other sciences, like psychology started to help with regard to the psychology of work, and it's really made up of multiple sciences. That's the great thing about Human Factors. So it's cognitive science, it's medicine, it's bench research, it's safety science, it's organizational psychology, clinical psychology. So it's made up of, many different sciences. It kind of takes the relevant parts that are important for a human system interface which is the macroergonomics, or human machine interface, which is microergonomics, which is a lot of where you see human factors being applied, like for helping the design of computers to work better.
Yeah, wow. Well, I know one of the other areas, Mike, that you have a lot of passion around is understanding the neurobiological impact of burnout and chronic high occupational stress over time. And you're getting ready to do a presentation to your own group, Human Factor Ergonomics Collaborative, on this topic. Can you explain to us a little bit about how the chronic workplace stress can impact a person's brain from a neurobiological perspective?
Yeah, sure. That's what I've been understanding it to be, which has been over the last few decades, actually. Um, Amy Arnston at Yale wrote a great paper called "The Biology of Being Frazzled," and I think it was 1998, maybe. But she gets into the prefrontal cortex effects of stress, and of course, this maybe didn't sink in the ways, and I'm hopeful that the more we make of this, the more it will, is that it's really uncontrolled stress, the ones where the receiving person of stress can't control the influx of what's coming at them, where this really starts to have brain injury by a series of steps that are inflammatory cytokines is one, their neurotransmitter changes, their actual anatomic changes. For example, some of the excitatory neurotransmitters, glutamate, which some of us realize is involved in mood disorders and all, but it's kind of like on overdrive. It almost gets burned out by its overuse, and it starts wearing down and its connections in the prefrontal cortex. So that's why your cognitive changes can start to decrease from this chronic stress. So your glutamate system is worn down and how it connects at the prefrontal cortex. It affects your vascular system in terms of the high stress creates increased cortisol. We all know about that, but the idea of chronic stress, the allostatic load, cuts down the feedback system on cortisol. So it's on overdrive. This starts to create a cascade, this cortisol cascade, which then changes at the level of, on the little vessels, the endothelium.
Mhm.
The endothelium of the blood vessels, the really tiny ones, the arterioles, for example, they get stiff, our atherosclerosis sets in. What's really interesting that I've learned in the last 8 months or so is autoregulation.
I was looking at that.
Yeah, and autoregulation is basically there's nerves and blood vessels that are together, the neurovascular units. And what happens when those vessels get stiff, the usual attempts to regulate flow to the distal organ from there is affected. Our brain, for example, actually has a lot of autoregulation. Once you're doing a certain kind of calculation or problem solving, the blood flow needs to increase to that part of the brain that's specific. So that's autoregulation, and that's done. We're built by God in ways that automatically do that. That's autoregulation.
Mhm.
When the vessels start getting stiff, they can't dilate.
Mhm.
So that part of what you used to be good at, you're struggling more. And it's the trouble with this problem it creates small vessel disease from stress,
Mhm.
is that it's a very long preclinical period of time, and you're not getting the immediate feedback. Oh, there's changes, and I can see why. It's harder to see because of this over time thing. So that then affects why patients are coming to see you, which is your brain power.
Mhm.
You're not as good, and so therefore it's affecting patient safety, let alone the extreme harm it does to you as an individual. So what was found was uncontrolled stress can be affected by giving the clinicians or any human more control in the workplace. So feedback systems that can go from the frontline clinicians to senior leadership, extremely important. We also know that if from research on the brain's performance is improved, and we think maybe some brain protection if there's access to the top, so to speak. In other words, if the clinician or whoever the human is at the front line feels that they have access of getting information to the very top where the onset of the stressors can be flowing through, right? Because you got regulations on the outside and you got senior leaders that have to make sure these things get done. Access to the top can actually help protect the brain and also improve performance. While you're under this stress, your brain performance can improve if you know you have an access system. So that's what is so remarkable and really leads a lot of support to people that have been theorizing about how to make organizations more efficient. A guy named William Passmore, who applies human factors in a system point of view. So he's a big proponent of jointly optimizing the people part of a hospital and the technology. So socio-technical joint optimization. And he also talks about sensors, environmental sensors. We've already got it somewhat better by the fact that we have patients and patient experience that funnels back to senior leaders. But the other environmental sensor that we've missed is clinicians doing the work. So in healthcare, it's both patients and clinicians that are the environmental sensors that need feedback systems to senior leadership. So it's really important for the health and well-being that we find ways to get feedback systems to healthcare leaders.
Absolutely. And, our friend and colleague, Dr. Paul Lachant, has one of his solutions is actually talking about, recreating the huddle on the front line to build in that feedback system to senior leadership. So there are solutions and ways out there in order to build those feedback loops in. But I think you're right, Mike. I mean, that's a key component, I think, to really reducing the systemic burden on physicians and nurses is really having that built-in feedback system, because there is a big disconnect between hospital leadership and frontline leadership, even, and middle management. There's disconnect between all of them. And so I think the key is connecting all those through system change and building in those loops. So I agree. But the good news is we have neuroplasticity in our brain, right? So a lot of people still have that, we're both psychiatrists, everyone. So we have that, neuropsychiatry background. And, a lot of people don't even know that we have neuroplasticity and that we can rebuild our connections. And so if there's, what Mike has been talking about is chronic stress over time and its impact on the brain and the body with the regulatory system, and the autonomic nervous system too. But you can reverse those changes in integrative medicine. We see that all the time with nutrition, lifestyle adjustment, decreasing stress. And then you mentioned something too, Mike, about, if as a physician, if I have some brain impact from my cognitive load at work and it's been going on for a couple of years and I'm just like at the brink, but we're redoing how we communicate to our leadership, and some things are being discussed and things are starting to change slowly, that it actually might build in a little bit of a buffer for me developing an actual physical manifestation of the stress. So instead of me going in and having a stroke due to stress with hypertension, I might be able to kind of recognize that that's happening and get some help with that and some attention. And then knowing that there's hope that things are going to get better and things are changing, that also builds in a buffer for neuroplasticity. What do you think about that?
I agree. And what is the jury's still out about is how long we have before it's not reversible. But that's what the studies that were done were showing, that it is reversible. Certain parts are. And it seems like I'm not sure about our amygdala, which is the emotional brain. That seems to get larger with the high stress. I didn't see the research about how that can turn around. The prefrontal cortex, yes, if you stop the incomings, kind of. What the jury's out about is how long we have. So makes an important thing. Since we don't know, let's get on this. Let's do what we can now. And it increases the sense of urgency, I think, these medical issues. And I hope it makes more clear it isn't just necessarily the right thing to do for the individual and patients, as we've talked about, but there's probably going to be more and more issues legally, I think, that are going to come from this. Certainly, in Europe, European OSHA equivalents are more willing to make those steps about what the toll of high emotions on the health. I think this kind of information may help us in the United States a little bit with more discrete issues of harm and workplace injury that I hope will become more clear and basically help our checks and balances that aren't there that about it. We do need to make sure the workplace is safe. And by that, we also mean things that are high emotion, high stress, that without control, that can be done. Now that we know there's interventions, better control, better feedback, why can't we do something about it?
Absolutely. And, Mike, for our audience members and healthcare leaders listening to this podcast, or anyone actually, if they're interested in learning more about the HFE model and its application in healthcare, what's the best way for them to find out this information?
Oh, especially what I've been working on is like its use in the organization. So certainly can use my website because I've accumulated a lot of what the work I've done. And then in the papers, there's lots of references. So my website is www.michael, M-I-C-H-A-E-L, R, middle name Russell, so it's R, and then Privitera, Privitera, MD.com. So there's all kinds of things that if people are interested can download for free. There's no cost. And I kind of explain a little bit about why it's important in different areas.
That's wonderful. And, everyone, I'll have all of those links on Mike's bio page on my website, as well as we'll be posting those links on social media as well. So you'll have access to all of that. Well, Mike, are there any last words of wisdom that you have for us regarding, our discussion today?
Yeah, I think there's hope by basically a biopsychosocial approach to burnout, to realize there's many reasons, and the evidence is accumulating on the bio side why we have to take these steps. So not only legal recourses, but the well-being and sustainability of our healthcare workforce. That things can be done, and they should actually, because it helps organizational efficiency, as per William Passmore, it's actually going to help your bottom line to do something about it. So it's not like it's one more add-on thing that's going to cost you more. It actually should, in the long run, be more efficient and actually make your organization better.
Absolutely. Well, everyone, I know this has been a packed session full of lots of information. We're so grateful to have Dr. Privitera with us today, explaining all the updates in HFE with regards to healthcare burnout. And thank you all for tuning in. And I will look forward to having Mike back again to keep the conversation going. Thanks again, Mike, for being here with us today.
Absolutely. Thanks for the invitation.